Dr. Bertagnoli is now here, but now we come to the presentation from Dr. Steib. What assessment for prosthesis that goes wrong?
Thank you, Patrick. So I tell you to excuse me because we will repeat certain things, but I think that it is very important to repeat to learn better. And so we can start with what to do when you have a prosthesis going wrong. I think that it's very important to know what is the problem without to decide if I do surgery or not and which kind of surgery. So I think that first the decision is clinical. You have to know if you have a discogenic pain or a facet pain. You have to know if the problem is neurologic. You have to know if it is loading or moving, and this is the problem of prosthesis with the movement. The second examination is the X-ray, because with an X-ray you can know what is on. Here the prosthesis inside the canal. Here is too lateral, so you can have some impingement with the nerves. Here you have some luxation of a prosthesis, and this is prosthesis had a movement after an epileptic crisis. So for me it was a surprise, because when you learn medicine you have always epileptic crisis, and during your normal life you see nothing. And here it was the movement of this prosthesis. I think it is 12 years after the surgery you have this movement with an epileptic crisis. So here you have some subsidence. You have the prosthesis not enough inside the disc. You have this strange construct, and this prosthesis is upside down. So sometimes it's very interesting to look at the X-ray. You can have some strange things like scoliosis here, and the question is the prosthesis was inserted before with already scoliosis, or the scoliosis is there after. And sometimes you have to ask to the patient what is the situation where you have pain. You see this prosthesis in a regular view, you say it's normal, or why do you have pain? And you ask to a patient, you have pain when? And she said, when I do my spine flexion, and when I have seated. So if you do the X-ray seated, you see that you have mobilization of the prosthesis. Another examination, very important, is the CT scan, because with the CT scan you see very well the bone, and so you can be sure if you have some arthritis with gas here in the articulation here, and with destruction of the articulation. And sometimes all is correct, and the pain, this woman has a prosthesis for a long time, all was correct, and she was pregnant, and after the birth of the baby she had pain, and you see that she developed with the hyperlordosis of pregnancy, a lysis that she had not before. The MRI is not important for the index level, but you can see the adjacent level, and you see you have modic signs. And the myelogram is certainly very important if you have a root problem, because it's very difficult to see where are the roots with the metal of a prosthesis. So you can have a dynamic view, and you can have a myelocytic. And here you see the contact between roots and the prosthesis. The discogram is also important if you want to know if pain is coming from the index level or the adjacent level. Sometimes isotopic scan can be useful if you think that you can have mobilization of a prosthesis between bone and metal. You can use also infiltration to be sure that the level of the pain is at the index level. You can test the facet with a block test. You can test the roots with infiltration. With EMG, you can know also if you have a radicular problem, and you know the level is, it is the level of a prosthesis, it is the level above or below. The conclusion is that it's very important for you to know what is the problem, because you have to take a decision, and you have absolutely to know where is the problem, and so you have the solution, where the pain is coming from, and what we have to do to cure the patient. And finally, after that, you can decide if you do the surgery and what kind of surgery you will do, a posterior approach, an anterior approach. You let the prosthesis in place, you do place for the nerve, and you do a fusion, or you replace the prosthesis. Thank you for your attention. So, excuse me, I have a train to join, so I have three papers coming along. Yes?
Yes, the case that you showed with the disc myositis, 6 years down the line, she has a lateral nerve compression of the same segment. How will you treat that surgically?
It's my next topic to explain what I can do. But it's sure that I think that again, you have to analyze the problem. And if you speak about roots, you have absolutely to know if prosthesis is involved in the root compression, or it is the behavior of the articulation and the movement. So we have to discuss the secondary arthrodesis in case of prosthesis failure. And again, the first question is why to fuse a prosthesis is not because you lose faith and you say, oh, prosthesis, it is a shit, I do a fusion. You need a very good reason. And for that, as I present you, you need a good assessment. And when you decide to fuse, your decision is I remove the prosthesis or I do a fusion in place. And if you do a fusion in place, you think that your prosthesis is like a cage, and you play with your prosthesis. There is a big difference between cervical and lumbar, because in cervical you know that the anterior approach is not a problem. And finally, in a cervical spine, what do you want to do else but to remove a prosthesis and to fuse or to change the prosthesis for a new one? In lumbar, you have seen that the anterior approach is very difficult for removing the prosthesis, and perhaps it's better to do a posterior approach when it's possible. So you have the choice in procedures. Very quickly, I show you what you can do with a prosthesis if you do an anterior approach. You can also decide to change the prosthesis. In the lumbar spine, with your assessment, you know if the problem is the facets, you know if you have hypermobility, you know if you have translation. You have seen that you can have scoliosis, and we discussed about that this morning. The prosthesis can be too small, and for that you have subsidence. Very often it's not push enough. And I have experienced that sometimes your prosthesis is in flexion like that. It's generally painful, you have no movement, and you stretch the roots here because of the elevation of the posterior wall. And it's one of my answers. Sometimes you have not to remove a prosthesis, you have to close posteriorly if possible, or you remove a prosthesis, so you have a challenge. It's true that sometimes you have no reason, you don't know why there is pain, but you know that it's the index level that is painful. Sometimes you have to deal with radicular pain, and generally the prosthesis is too lateral, and recall you that for the lumbar spine it's mandatory to have an anterior X-ray during the surgery. In the cervical spine you have an uncus, you know where you are, but sometime in the anterior approach of the lumbar spine you think that you are in the middle and you are not in the middle. And if you are not in the middle, it's not beautiful in the X-ray. The behavior of the prosthesis is not good because biomechanically the prosthesis has to work symmetrically. And finally, you can have the corner of the prosthesis in the recesses and with pain. And again, if your prosthesis is in kyphosis, you can have radicular pain. So finally, when you decide to fuse the prosthesis with the posterior approach, it's very easy, but I will explain you the strategy. I think that you have to use polyaxial screws. This is important because when you use polyaxial screws and you do a posterior compression, you compress your prosthesis and you put your prosthesis in lordosis. If you use monoaxial screws, you will have a problem because if you want to have a lordosis, you have to distract because if you compress, you reduce lordosis, and it is difficult to put your prosthesis in compression. I think that it's important to do a Smith-Peterson osteotomy if you want to be sure to have the maximum of lordosis. And certainly it is very important for a fusion to have a lordosis. You know that for a prosthesis, the prosthesis has to be neutral and the patient do himself his lordosis, but if you do a fusion, you need a lordosis, and you can see the pelvic incidence if you want to know and to calculate how much you have to put lordosis in your construct. So, look, this is your prosthesis, bad. This is what you want to have. So you put your screws, monoaxial screws, you put your rod, and when you put your rod, you have that. You have an elevation of the upper end plate, and it is difficult to compress with this kind of screws. So I think that if you use a cage, and it is the philosophy of the cages, you use polyaxial screws, and you do that. But when you use polyaxial screws, and when you compress, you have some spondylolisthesis of your prosthesis. So I think that you need to compress and to restore lordosis, but you need also to pull back your superior vertebra. And it's for that you have to put your screw, your upper screw deeper. And if you do that, you can obtain the good results. This one you wanted to have at the beginning. So, one example, you have this prosthesis going bad, and you see that you can put your prosthesis easily in lordosis, and you can calculate the lordosis into the prosthesis, and you have a contact of the prosthesis. If you have no contact between the end plates, it's not a cage, it's nothing, and you will have dismounting, and I will show you some cases like that. You have another regular case here where you see that if you don't do the Smith-Peterson osteotomies, you obtain lordosis, but quite not enough, I think. Another case, multi-level, you see that this prosthesis is in Chi4, but you see that you have a problem with the facet and you have a problem with the disc above. So I think it's important to do the two levels if you want to have a result. And again, if you use the construct, you can restore a lumbosacral lordosis. So if you use monoaxial screws, you will have problem. This is not a dynamic construct, it's a rigid construct with peak rods. And with peak rods, it's very difficult because the shape of the rod is imposed by the industry, so you cannot choose the shape of your rod. And you see that here you have a fixation without lordosis and with some spondylo. And here, it's quite good. So I thought at that time that I was better than this surgeon, and I realized this surgery, you see, as I told you, if you don't treat like a spondylo, you have the spondylo after the surgery. And because you have no contact here, you have no stability. And if you have no stability, you have a dismounting, like you can see here. And if you use polyaxial screw, and if you put this one deeper, and if you have a good fixation, you can obtain a wonderful lordosis, and this is stable. Another case. Here you have, it is a diagnosis, and you can understand that this patient is a little painful. So you see that this is the prosthesis, this is the adjacent level, and the adjacent level seems good. I thought that, and I performed my surgery, and I put my patient in lordosis, and I was quite happy. And you see, this was just after the surgery, and with the follow-up, you have a catastrophic position of the spine. And so I had to return and to put a cage here and to restore the lordosis. And fortunately, till now, the follow-up is good. Another strange case, you have seen this one, is that lady with a scoliosis. We can understand that it is not only a problem of prosthesis, it's a scoliosis. So I perform the surgery. I use monoaxial screws because I think that for reduction of scoliosis it's better to have monoaxial screws. It was a mistake because if you want to compress the prosthesis, you need polyaxial screws. So I was happy with that result, but I had this dismounting here, and you can see the follow-up, and with the polyaxial screws, a real lordosis in the lumbar spine. So beginning and final results with polyaxial screws around the prosthesis. So to finish, finally, the prosthesis is bad, and you are sure that you have a facets problem. You prove it with block tests. You have here your prosthesis. And why? To fuse, you can use a total intervertebral arthroplasty. You have here the case. There is a pain, inflection extension. This is PC to Macintosh, I think. And you can see you have here the total intervertebral arthroplasty. I show you that case already 2 years ago, so that means that I have 3 years follow-up now. And you can see that you can have flexion extension with a total intervertebral arthroplasty. We think about prosthesis, and prosthesis is 1/2 of the spine because we treat only the disc, and if we want to carry on with the philosophy of of arthroplasty, we have to think about the facets. So finally, a secondary arthrodesis is generally easy. Use polyaxial screws. Put very deep your upper screws. Do a Smith-Peterson osteotomy, a posterolateral fusion, and so you will obtain a good lordosis without antilisthesis. And you have seen that sometimes you have difficult cases, and you need absolutely a good pre-op assessment to understand what is the problem and to choose a good solution. And perhaps in the future, we will use the total intervertebral arthroplasty. Thank you. I will carry on with the last topic, and like that we will have time for questions. So we discussed with Patrick Tropiano about indication to remove a prosthesis. Again, this is the same question we had before, and again, for the lumbar spine, it is a very difficult decision to take, and you have to think a long time before. So, if the prosthesis is going wrong, it's because you have problem in the index level. You can have back pain, you can have leg pain, and sometimes you are afraid because you see that you have a danger, neurological or vascular, and because of that you can decide to remove the prosthesis. So in cervical spine, it's very easy. You can choose to remove and to fuse the prosthesis, or to remove and to put a new prosthesis if you know the problem. Here, you have this prosthesis in kyphosis. Perhaps it is because at the beginning we made a mistake and this prosthesis is too small, and the center rotation is not at the good place, and you have a flexion. But here you see, it was one case with a fusion done by myself, and I had an adjacent level, so I decided to remove the plate and to put a prosthesis. This prosthesis was done 10 years ago. It was one of our first cases, and this prosthesis was too small, and so I decided, on the CT scan after that, I discovered a pseudarthrosis. So I decided to come back, to change this prosthesis and to put the prosthesis in the pseudarthrosis. And you can see the follow-up, and the follow-up now is more than 10 years. And I have to tell you that it is the girl with epileptic crisis and the disc in L5 as well. So to go with an anterior approach, you have seen that before. It's a major surgery, and it's sure that you prefer to do that. This is always the same with the epileptic crisis, and she is going very, very well. So a new anterior approach, that means that you have to push the vessels, and again, the show does exist, and you have to consider that it is always better to go with a posterior approach to do the job. But sometimes it's mandatory to go with an anterior approach. For me, I have only 6 cases in 28 years of disc arthroplasty. So you see that it's very rare, but in that case you have no choice. You have to remove the prosthesis because there is a danger for the nerves, for the vessels, or mechanical reason. You know that that man is a Danish surgeon, and he published a lot about Dutch. Excuse me. But the beginning is a D. Yes, and he is the specialist of removing prostheses, and sometimes you wonder why he wants absolutely to remove his prostheses. Yes, there is some indication, but for him, when he sees a prosthesis going wrong, he wants to remove a prosthesis. He had an internet site where you can go and you click, do you want justice? And you are directly in communication with a lawyer. And it is certainly because of him that we had the death of Charity Disc, because they had so many suites that they had to stop with the prosthesis. So I think that when we have a complication, we have to find the solution, and we have not to cry and to say, fire, fire, and no, there is a fire and there is a fireman. And to do papers against the surgery is a paper against us. It's a paper against the surgeon. So I prefer to forget that man and to explain to you how to do. So again, for me, it is 6th anterior approach in my life, and I think it's not so much. So not so many. Okay, so you need a strong indication. You need to inform your patient, and he has to agree to the schedule. You need absolutely a pre-op angiogram. You need experience. And when you think that it will be difficult, you have to ask to a vascular surgeon to help you, and not too far or present. And I will show you a case where he was present immediately because I knew that it will be difficult. So that case is not so difficult. Is a charity I put in the 90s, and I removed in 2000, and I don't know, it was certainly 15 years later. I was afraid because of the disc going in the canal. But you are right. Today I can go to the posterior spine and to compress, but if you compress, you have to pull back, because if you compress without pulling back the superior end plate, you push the core in the canal. So I did that. It was very, very easy to do. You see, you have the movement here, and you imagine that too much flexion and too much extension, and it's near the nerves. So I remove it, and it was a very simple surgery, and it's sure that in L3, L4, the vessels are far from the spine. It's not the same in L4, F5. So you see the behavior of a patient, and now we have, I think, more than 5 years follow-up. Here, it's a mistake during the surgery, and I demonstrate you the mistake. So we speak about early removal. If you have to go back to the surgery, go immediately, because if you go immediately, it's very easy. 5 fingers, 2 hands, and you push the vena cava without any problem. So if you have a patient just after the surgery with a problem, and you see that there is a problem, go back immediately. So I show you the problem. You see here, the prosthesis is perfect, but you had only one anchor here, and the second is coming, and with the second, clack, it is in the canal. So I said, it's nothing, and after the surgery, the patient had a pain. You see that the recesses are small here, and you have a post-op view. It was very easy to go, very easy to remove, and you see now the prosthesis is perfect and the result is perfect. If you wait, I don't know, I wait, and you come 1 month later, it will be difficult and catastrophic. So if you have any reason to think that we need to go back immediately. This is a regular case. You see before the prosthesis, you see the prosthesis, again, too much inside the canal. I had to come back at distance, but it was not so difficult. And you see that the prosthesis here is in the narrow recesses because of the prosthesis. And here it's interesting. You remove the prosthesis, you put a cage, and after that, you do percutaneous osteosynthesis, and the result is quite good. This is a difficult case because it's a woman. She had first, a long time ago, a fusion. She developed an adjacent level disease. I put a prosthesis, and this prosthesis was in in Kaifo, like you see here. And she had root pain. And I said she has root pain because we have a flexion, you have a triangle, the basis of the triangle is there, so you stretch L5 root. And I wanted to remove a prosthesis and to put a cage in extension, in lordosis. So we went with the vascular surgeon, and it was catastrophic. You see that the double G catheter, and we made 10 holes in the iliac vena, 6 liters. And when I removed the prosthesis, 1/2 of vertebral body came with the prosthesis. So I had to put that cage, and you can understand that I wanted to restore the lordosis, and I could not restore the lordosis because I had no more vertebral body and end plates. But finally, the result is not so bad. You have here the final construct. It's just after the surgery with the double G catheter, and this is at distance. The result is quite good, but I think it was a bad idea. Certainly it was better to go with a posterior approach and to do the fusion. Here you have a mixed case. It's a case on 10 years or more. You see that this lady had 2 Modixine discs, so I put 2 prostheses. And finally, this one was going in Kaifo. And so I decided to put a posterior fusion, but she was still painful. So it's on 10 years, the story. It's not week after week. And she had root pain, and I decided to remove the prosthesis. I had no place to put a cage, so I put bone. But she was still painful. And you see that, and you will see that she developed an adjacent level here. And finally, I decided to do that fusion. You have here, as I told you, a good lordosis because you have Smith-Peterson osteotomy, and you have polyaxial screws. And I performed surgery on Friday just before coming here. And you see, that man is my CD number 7. That means that I operated on this man in 1985, February. He developed all the complications you can imagine in a new surgery because I performed one of the first 100 CD in the world. So we had absolutely no experience. So we forget to do the contracurvature. He did pseudarthrosis, he did adjacent level, and he did another adjacent level, and I decided in the 90s to do a disc arthroplasty. You see that the disc arthroplasty is working well, and during 10 years, that man was a champion of swimming in France, and I follow him for 30 years, and he developed, you see, discopathy in L5 as one. So I decided, no, we do the fusion till the pelvis. I performed that on Friday. And I do, as I told you, polyaxial screws, Smith-Peterson osteotomy, and compression. And you see that this is the lordosis. But I think that we cannot let that because you have absolutely no anterior support. And because of that, I think that I have to do a 7 case with removal of a prosthesis and a new anterior approach. Because he had already an anterior approach here because he had here an ALIF done 15 years ago or something like that. Okay, thank you. I think that I have a taxi and I have to let you.